Good afternoon, everybody. Thank you very much for joining us on our latest Fireside chat with our team here at Healthmonix. We are here today to discuss key facts to know about MIPS measures. Our panel for today includes the CEO and President of Healthmonix, Lauren Patrick, Tara Kalra, I got it, Tara Kalra, MIPS measure specialist, and our friend Josh Hall, who is also a MIPS measure specialist here at Healthmonix. A couple of introductory things that I want to go over prior to us starting with our webinar. If you see over on the right-hand side of your screen, we have two sections that I would like to point out. The first is the question section over here where you can ask questions to our panel, and if we have an opportunity to get there, we will move forward and get those questions to you by the end of the call. Also, there is a handout section below with some information about MIPS and information about Healthmonix for you to share. If you have any questions after the program, you can reach out to us at the information that you see here on the screen, the contact@healthmonix.com or our phone number, or just go to mipspro.com and visit us there. I have a number of polls that I want to put out, real quick polls that I'm going to launch for you guys to go over, and then we're going to get to our specialists. The first poll that we're putting out is, what is your level of knowledge of MIPS measures?
You want us to answer that, Mike?
No, I don't want you to answer that. I usually get a couple people that marked expert or advanced on here, so I'm interested to see. All right, another 15 seconds, I'll give this. All right, close this one out. And it looks like we are more than 50% are in the intermediate range, and then we have about 30% in novice and 15% in advanced. So that's pretty well split across the board. Now we're going to go into what brings you to this webinar today. Lots to read on this one, sorry. All right, another 10 seconds. All right, great. Looks like a lot of people are joining us today trying to find out just anything they can about MIPS, and that's what we're here for, as well as learning more about measures. All right. And then last one is, we just wanted to get a little background on who we're talking to today. So if you don't mind quickly filling this one out, is what is your profession? All right, great. Another couple seconds here and we'll get on with the show. Fantastic. Thank you very much for participating in our polls. We appreciate it here. All right, well, without further ado, I am going to hand it over to Lauren Patrick, our host today.
Thanks, Mike. So what we wanted to do today was we really wanted to delve into the matter of quality measures. Healthmonix has been involved in developing and implementing healthcare quality measures since before the beginning of the MIPS program and before the beginning even of PQRS. We've worked with specialty societies to define measures. We've woven measures into quality improvement programs, and we've implemented all of the measures on the QPP program that are in the CQM, and we're almost done with all the ECQMs. So We have a lot of experience with regards to those measures. Tara and Josh are part of our full-time staff. They work year-round with these measures, implementing them, perusing the specs, working with our clients to make sure that everybody's got an understanding, and really working to get the most accurate quality performance data we can get in the easiest manner we can. And we'll talk a little bit more about that in a little bit. But I really wanted to have an interactive discussion with Tara and Josh to let them be a little bit heads up from their quality measure work, and talk to the rest of us folks about what they're doing and some of the nuances, and to respond to any questions. I do want this to be a dialogue, so I think Mike said if you have questions, type them in the question box. Personally, for some reason, I can't see that question box, but I'm sure Mike and Tara and Josh will be able to, and be able to help understand. So with that, I want to delve into measures. We're going to start at the basic level, but we're very quickly going to get into the geekiness of measures. Tara and Josh both have very mathematical backgrounds. I think they both have degrees in math or stats, as well as a whole host of other qualifications. Josh has been on our team for over 8 years, I think, and Tara came to us with, I think, about 10 years of experience. So definitely a lot of background in the measures. So I want to start basic. Josh, can you give an example of a numerator and a denominator, and we'll go from there, just as kind of a level set?
Yeah, sure. So at the basics of all measures is quality. So we're going to be going over quality measures today. There are other measures within MIPS, such as cost measures, and some other things like PI. But we're going to be looking at quality measures. And when we're thinking quality, we're just saying, okay, is at its core, are doctors treating patients, providers treating patients as they ought to be treated? So that's what measures are. We're measuring doctors and how well they're treating patients based on their own specialty. So there's measures out there for diabetes, psychology, every single specialty. And I'm sure you guys know that if you browse any measures at all. So when we're looking at numerators and denominators, it really just goes back to simple math. You're looking at your denominator. This is your bucket. What is the population we're looking at for this measure? Often the denominator is really simple stuff. So is the patient old enough to be in your group that you're looking at? What's their gender? What sort of encounter are they coming in for? Is the procedure applicable? Often these are CPT codes, simple encounter codes, that say, okay, we're going to look at this group of patients to be in our population for this measure. So that's the denominator, that's in the bottom. The numerator is the thing that the doctor's actually being graded on. So this was what we traditionally like to call a quality action. Often for process measures, this would be something like, did you screen someone for what they ought to be screened for? So for example, measure 226 is tobacco screening. Are you asking patients whether they smoke? Are you doing a counseling session with them? There are also outcomes measures. So measure 1 is seeing, okay, are diabetic patients, their A1C levels, are they within a correct range after you're treating them? And all of these go into the numerator. So in short, you get your denominator, bottom part, numerator, top part, and it spits out a percentage that says, how well are you treating them? Are you treating them well? And that might be like 90%, or are you treating them not so well, maybe down in 30 or 40%.
Thanks, Josh. So Tara, Josh mentioned the term outcome measure, process measure. Can you elaborate on that a little bit?
Sure. So there are different types of measures that are created, and the ones that we see most frequently are going to be the outcome and the process measures. Process measures tend to look at more of something that was done to a patient. So like Josh said, are you doing certain sorts of screening? So there's other measures like breast cancer screening, colorectal cancer screening. Those kind of measures are looking for certain medically backed processes that we expect to happen on patients in order to be following a expected standard of care. There's also not all screening measures are process measures. There are other types of there are other types of measures that require diagnoses in order to be part of the denominator, as Josh was talking about, such as the diabetes measure. Amongst those patients that are diabetic, are you doing a specific set of procedures on them in order to be correctly managing their condition? Now, that's different than the outcome measures. The outcome measures really look for it's almost like a metric. So you're looking for a value to be ascertained or to be obtained at a certain point in time in order to meet that measure. There are measures such as controlling high blood pressure. So patients who have hypertension, what are their outcomes as far as what their BP, their blood pressures are at a specific point in time? So that means that we take your vitals, if you have them, and we can bucket you and see, are you hypertensive? Are you controlling your high blood pressure, or are you not? If you're controlling, then you're meeting the performance. So it's those are the two bigger buckets of the types of measures that we really see. There are patient satisfaction measures that are out there as well. Those are a little bit more just looking at how feedback of the patient's experience of care. We do have a couple of those, but really the bulk of them are going to be the process and the outcome measures.
Thanks,
As a side note, CMS is actually focusing on outcome measures a little bit more now than they have in the past, because we really want to make sure that we are taking care of our patients and it's working.
So can you guys elaborate on that a little bit? A process measure being something you do versus an outcome measure. Doesn't the outcome measure depend a lot more on the patient? And is it fair? I know we didn't talk about this question ahead of time, but is it fair to evaluate a physician or another clinician on the outcome of the patient when the patient to some degree has some influence in terms of whether that measure is met or not? How's that for a question for you guys?
Well, I think often I would just say, yeah. I mean, your job as a physician is the patient's, like, all of their care. So it's both, did I tell you what to do, or am I actually treating you? Am I building a relationship with the patient where the patient trusts me enough as a doctor in order to actually follow through with the care that I'm giving them? So that's one thing, is kind of this relationship that you're building with your provider.
And accountability.
And accountability, right. And some of them are just surgical procedures. I mean, you can say, you know, yeah, sure, I did surgery on them. Well, that's great. How well did the surgery go? Are they actually healthier? Or if you're helping someone, for instance, measuring physical therapy. A lot of the physical therapy, sure, it depends on the patient actually doing the exercises and such that the provider is asking them to, is training them on. But a lot of that is on the physical therapist who is helping them week by week. So if we're going to look at someone and say after 3 months, are they better functioning from a physical side of view after, say, a surgery like a hip replacement, then yeah, I would say that's an outcome measure. And sure, the patient, you know, they got to follow along, or else, you know, what else are you going to do? You know, you got to treat the outcome. Otherwise, simply just doing the thing isn't enough in those instances.
Now, there are some instances in which CMS is, and providers actually bring up exactly what you brought up, Lauren, and they're like, well, it's not my fault. Like, certain things are out of the provider's control. For example, they refuse to have their blood pressure taken. I made that up, but something like that. So if there's a patient refusal, there's a concept that is implemented called denominator exceptions. And denominator exceptions, what it is these patients technically do have the condition, or they fall into the bucket that's required for the denominator, but it's not to the fault. It's certainly the physician is able to do all that they can, and they still are not able to ascertain what they need due to specific reasons that are identified as acceptable reasons by the medical community or the measure stewards. And if those situations happen, what happens then is we identify that not as we don't ding a provider for that. what we do is we make an exception for that patient, and then the provider is not dinged for that situation, that patient.
So let me ask
that's the way we protect them.
So my question would be, when you say you make an exception, so back to the basic foundation of numerator and denominator, does it come out of the numerator? Does it come out of the denominator? So let's say I have 1 patient out of 10 where I can't do it. So tell me what the performance would be taking that patient out. Let's say I met it for 9 patients,
Sure.
and then for the 10th patient, I just couldn't do it. What would my performance be?
So it kind of depends on where the patient's being taken out. What we're talking about here is we're talking about what are called denominator exceptions. And this is where someone met that denominator bucket. So say they were older than 18 and they were a female patient and they had a breast care screening for breast cancer. There might be something called a denominator exception where the short of it is there is a valid excuse for not treating the patient the way they ought to be treated. In some cases, this they might be they're allergic to a medication, or if you're trying to say there's one for anesthesia where you're trying to test their temperature for hypothermia, and well, maybe there's a reason that their temperature is lower because of a condition or an emergency situation. So all of these, there'd be exceptions. So you would be in that denominator and you kick them out of the numerator. You would have this, so say you had 9 patients who are met and 1 exception, your percentage would stay at 90% because it's not affecting it higher or lower. The other one would be an exclusion, which means you're not even in the denominator bucket at all. So one of these common ones is often people who are in hospice are excluded from denominators because of the end of life care that hospice entails, that they're often saying, okay, do you have any of these hospice codes? We're going to exclude those people before we even get to the numerator.
Okay. So somebody asked in the chat, I have a secret way to get to chat. For example, if you can't measure somebody's height, what would you do with the BMI measure? Would that be an exclusion? Would that be an exception? Would that be a not met?
Well, we would have to look at the specifics of the measure in order to answer that. Usually, from my recollection, you need to have height and weight or the BMI in order to be met. I can look it up actually right now real fast and answer you.
Yeah, it looks like Kelly has something over here regarding that measure. So with regard to this, there are different reasons for not documenting a BMI. And some of these are patients who just refuse height or measurement. So
Right.
if they're refusing it, you can't take it. I think that reason would, the reason of simply not being able to measure someone's height is pretty, pretty niche, I would say. And I think there is an element where, if they're, disabled or something, that's not possible. So I think in those instances, it's up to the discernment of the physician in order to say, I'm going to mark down when I look at this measure for this person an exception if it's available as a code, because they know that that's a valid excuse for not being able to measure someone's BMI.
So how do you document these exceptions or these exclusions? Are there G codes for this, or do they come out of the denominator somehow? How do we indicate that in our measures?
Right, so there are G codes, there's F codes, MIPS uses what we call HCPC codes, HCPCS codes, and what those do is they indicate a type of situation that has happened, such, for example, for the BMI, that the BMI was, one sec, let me just see. So the BMI is written and documented within normal parameters and no follow-up plan is required. So that G code actually indicates a specific type of action that happened. That's not to say that we don't have the capability of using other types of codes where they're appropriate. For example, ICD-10 codes, CPT codes, SNOMED codes, LOIN codes. We have the ability to leverage other sources out there, such as ECQMs, and we have other vendors that we work with, EHR vendors that we work with, who help provide us with direction and the appropriate types of traditional billing codes that we can implement into our registry measures as well. So if it isn't common, if it's not part of your practice to use these HCPCS codes, we have the capability at Healthmonix to integrate with your systems and pull those in where appropriate.
Is that what you guys are doing all year long?
That's part of
We
it.
spend a lot of time on it. We spend a lot of time on it. We're merging a lot of different sources together to help get the most widespread continuum of care for each patient for all our clients.
Thanks, Tara. I didn't think you guys were just twiddling your thumbs. So somebody asked, and this kind of goes to the concept, I think, of numerators and denominators. If a physician provides consulting within a home-based primary care practice, but also does inpatient work, how do those measures get calculated? Can you talk a little bit about what goes into, I guess, the denominator, because that's talking about what patient population do you include, and then even perhaps then let's say it could also impact your numerator. So talk a little bit about that. If you have a doctor that's practicing in 2 different locations, 2 different TINs.
So is that something about doing MIPS as like a group or an individual provider, Lauren? Or is that more of a measure question? Is that more of how they're reporting?
So I think there's two different components to that. One is when you report MIPS, your denominator is for all your visits within your TIN. So if you're practicing in one practice and then you're going into a hospital and you're practicing under a different TIN, then that doesn't get included in your MIPS denominator because it's a different reporting group. MIPS is very specific to, first of all, a TIN, a tax ID, a billing group, and then secondly, the individual NPI. And you can think about whether you're going to report individually or group, but it's always within the purview of that TIN. So a practitioner would never combine all of their denominators from both of those groups. However, if you had a patient that you were seeing through your home-based practice, but they were in the hospital and for some reason that's where you gave them their flu shot, you would still be able to include that flu shot in your numerator for that patient and get credit for that, if I'm not mistaken. You guys are the experts, correct me if I'm wrong.
No, that sounds right too. And also per just like whether they're inpatient or not, often measures dictate that. So in a sense, measures are pretty strict with what sort of encounters they allow into the denominator. There are very common ones, like common encounters like CBT, 99201, 99202, just simple inpatient visits. But often, if there are measures having to do with surgical procedures or various sort of diagnoses codes that have to do with hospitalization, they're going to have sets of CPT codes that apply there. So often simply consulting the list of codes that are applicable to a measure to be in there will let you know right away if someone's applicable to that population.
And if there is, MIPS Pro allows you the capability of going into visits and adding in manually to complete visits if you need to. So there is that capability. I'm not sure if it's license related or not, but I don't think so. So if you find that you have these eligible visits, but you're not getting your numerator codes, that will show up in MIPS Pro as an incomplete measure or an incomplete visit, and you can go in and be like, actually, I did provide the flu shot. You can click in and say the flu shot happened, and then you can supplement your data in that way.
And that's a good turning point too. So part of this is we're thinking, well, when we look at measures, you're just inundated with all these lists of codes. And we at Healthmonix, we actually started out a while ago doing, our system was gearing towards people who enter this data manually. So if anyone here in the webinar today remembers way back in the years of PQRS Pro and measures groups. You only had to do something like 30 visits for a measures group. You only had to have a certain number of instances, and it was a really easy process, which we've now made super hard because thanks to CMS with hundreds and thousands of visits and all these people. But at its core, what we do is we provide software that you can do stuff manually. So you can enter these visits manually if you don't have the codes. You can go in and you can check row by row. So one of the things Tara brought up, which is kind of interesting, is what is the difference between, say, having a visit or data that's incomplete and stuff that's ineligible? Like that's kind of a big deal in our system, right, Tara?
Very big.
So what does that mean if something's ineligible or if something's incomplete?
So if you, great question, Josh. So if we have, there's two different explanations. There's two different statuses that can make a visit not make it through and count towards your performance. And what that is if you have an incomplete visit, that means that you have eligibility codes, like you have an eligible visit, but we just can't find your numerator code. So we don't know if you met the performance or not. Or we found your numerator code, but so we think that maybe you potentially have the capability of getting the eligible criteria and then getting counted as part of your performance rate. Incompletes don't hurt you, they help you. So you can go in and complete your visits, and then that way you can boost your numbers up. Not cherry picking, it's making your data more complete. And then there's the ineligibility aspect. Ineligibility is kind of what we talked about with Josh earlier about denominator exclusions. Ineligibility can be that if a person's in hospice, we really don't have the capability or we shouldn't be measuring specific things. And so they're ineligible for this measure. There are other types of ineligibility measures or criteria, such as if we're looking for opioid use, and or not opioid use, let's look for breast cancer screening. And you need to be a woman for the CMS measure. You need to be for the CMS measure, you need to be a specific age in order for mammograms to be expected as part of your traditional standard of care. So women who are less than 45, or I forget what age it is, they're not eligible for this measure. Not to say that they shouldn't have mammogram screening, because if they have prior history, breast cancer history, or other sorts of factors that may increase their risk, that still needs to be followed. They're just not part of this measure and are excluded as part of the performance rate. So there's two different ways to not be included in a measure. The ineligibility means neither of them hurt you, but the incomplete visits, once you complete them, they can make your data much more complete. And the ineligible people are just, they're not part of the requirements for the measure.
Thanks, Tara. So I have two different things I want to pursue, but the first is somebody asked, can you talk about MIPS measures versus HEDIS measures? Tara, I think you're pretty intimately familiar with the differences between them.
So the really big difference with HEDIS versus MIPS is HEDIS requires certain eligibility criteria in order for patients to be allowed to be measured by the HEDIS program. There's a continued, there needs to be a, if I remember correct, there needs to be a continued amount of healthcare coverage, and there cannot be gaps in their coverage in order to be considered HEDIS eligible. On top of that, there are some other layers of algorithms as far as you being attributed to certain physicians. So there's an attribution process that goes into HEDIS as well, where you are basically connected to one provider, or based on how many visits you've had with those providers. That's kind of where the provider attribution aspect of it. And the big thing with MIPS is it's registry based. HEDIS is claims based. So we're registry based, and we use a lot of the HCPCS codes. I don't believe HEDIS uses HCPCS codes. They mostly use traditional billing codes.
So just one point on that, people can still report some MIPS measures versus claims. I know that CMS is
Absolutely
really kind of kind of discouraging that and limiting and narrowing that. But yeah, we believe that registry reporting is better, so that's going to be a jump off point for me to talk a little bit more about measures in terms of why use a registry. And I'm not trying to promote MIPS Pro, although if you're interested, you can talk to Mike. But the idea of some measures using data from other visits, some measures having a look back, some measures having a look, we call them look back, look forward, and look around. So Josh and Tara, can you guys talk a little bit about that, how we use that in some of our measures, and maybe give an example that, you know, the actual quality action or the outcome. Let's talk first about quality actions, and then I want to move to outcomes, because a lot of times outcomes are based on multiple visits. So let's hold off on that one, and let's just talk about look around as it pertains to a process measure to begin with.
Yeah, sure. So when we say look around, what we're saying is that there are certain historical data that matters for a full view of a patient's history, medical history, or there's stuff that could happen in the future that that you need to know later. So for example, if you have a surgery and then you need to know the outcome of the surgery 30 days later, you kind of get a full view of a patient's care. So a common example of a look back that we do is simply for looking for a history of disease. So if you want to know that someone's diabetic, you want to look back to see if they ever had a diagnosis of diabetes. Because if you're filling in kind of like your view of a patient within a measure, within a visit, you may or may not get that ICD-10 code on that date of service that all the other codes are receiving. So we need to look back however many years to see if they have a diagnosis of diabetes that we can just pull into that visit in order to calculate the measure. Other things, like I mentioned, for a surgical procedure, often numerators look forward to see the outcome of care. So if we have a date of service where you have a surgical procedure code, the numerator, the HCPCS code might say, hey, did this surgery go well within 30 days? Or even there are some ones that are much more immediate that said, you know, follow up within 7 days after this, and you're trying to see the outcome of that. So we have to look forward for the presence of a code. As a registry, we can do that. As claims, you kind of have to have all this data in front of you and organize it yourself, and it makes it a little bit more jumbled up. I believe, Tara, you have a good idea of measure 370. Isn't that a crazy one that also looks for data that's not in the reporting period?
Yeah, so 370 tends to be one that I've had to explain a few times. The reason being is that the look forward is quite long. 370 is looking for, it's a depression measure, and so the look forward is actually 14 months. So what this is looking for is a person with a diagnosis of depression, and then they're looking to see that they are actually well taken care of, in that at their follow-up, they have shown that they are no longer categorized as moderately to highly depressed. Because of that look forward, we don't look for those, what we call index visits or the initial visit, in the reporting year of currently 2020. We are looking for the outcome in 2020, so we got to look back 14 months and plus some for that initial visit. And then we find it's measured by, there's an inventory called the PHQ-9 score. And that PHQ-9 score is identified as depressed for that patient 14 plus months back. And then you look forward for the PHQ-9 score current day. So that's what we're able to do, is we're able to really traverse many months of time to find the continuum of care for one patient across time.
Right, so we're looking at years of data then in order to
Sure.
calculate measures sometimes.
Absolutely. Colorectal cancer screening, you could have met criteria for colorectal cancer screening if you had a colonoscopy 10 years ago. We can go back, if you give us the data for 10 years ago, we can get it.
And often those sorts of screenings, we need that much data, right? In order to know if you are getting your screening every 3 years.
Absolutely. You got it.
Great. Somebody asked if MIPS, this is kind of a side question before we jump back into it, is MIPS required by anybody? Do you have to do MIPS reporting?
Only if you don't want to lose a lot of money. If you're fine with that.
And you bill Medicare Part B, right? It's
That is
Medicare
also
Part B
true.
billing that
Yes.
gets affected. So if you don't do MIPS in normal times, there's a negative 9% penalty is if you meet the measures of you bill at least $90,000 and, oh geez, you have at least 200 visits and you have at least 200 patients, and I don't know, I'm not the expert here on that, but there are rules about when you have to report, otherwise you're going to lose that.
You're not part of an advanced APM.
Thank you, Mike.
Yeah, so there are some things that you need to meet. And there's other things as well that might qualify for you being like a smaller practice or having different reasons. And yeah, there's a lot that can go into that.
So I want to talk about measure tags a little bit. Some measures, what we've been talking about is we've been very visit focused in our discussion so far, and I hope people are getting something out of this. Like I said, we love to geek out on this stuff. So, but there's measures that where you measure them every visit, like did you check the medications, right? Yes, no, you want to do that on every single visit. But then there's other measures that are like every patient or every episode, or there's some measures where it's most advantageous or somewhere it's most recent. So can you guys talk a little bit about those measure tags and all the various kinds of measures there are and how the heck we keep them straight?
Yeah, so if you ever open up a little measure specification, CMS has come up with some terms that aren't really straightforward that mean what a reporting frequency is. So how often do I need to report this measure for this patient this year? So the most common one is patient process, which is the most advantageous visit. So say you had a patient and the measure is seeing whether you treated them a certain way throughout the year. You might have done it 5 times. And because it's the most advantageous, if at least one of those 5 times you met the measure, then for the whole year, that patient met the measure. So that would be a most advantageous. So you're just trying to see throughout the reporting year, did you do it at least once? Often for those types of measures, you're not going to see them more than that many times, which is why they take the most advantageous tag. The other one Lauren mentioned is there's a lot of measures that you just need to do every time. So I believe this past year, measure 47 was nixed because it was very difficult for providers to do because it required, or it was either last year or this year, 47 or 46, having to keep track of a current list of medications for the patient. And that's something that they're saying, well, you need to do that every single time that the patient comes in. So some of these things are necessary. You want to do it every time. But in terms of reporting, it was a bit of a burden for every provider who is contacting this patient to keep track of this full list of medications. But for those types of measures where it is a visit or a procedure, that every single time that that patient comes in, that's going to get counted in your performance. So it's going to count it every time.
And then there's measures like the flu shot where it's twice per year, right?
Yeah, so what we call measure tags is what we do in our registry is we tag measures based on their reporting frequency. So measure 110 is a perfect one. It has 2 different flu seasons. There is one at the beginning of the year and one at the end of the year. And you can have one instance at the beginning of the year and at the end of the year. So we create a special measure tag in our system which tracks that reporting frequency. So for every patient, they can get reported up to 2 times for measure 110, which sees if they got their flu shot.
So if I'm a provider, how often do I have to document these things in my EMR?
You document them as they happen. We pull what's necessary. So you document your standard, your patient care, and then we will pull what is required, the appropriate visits. We will pull the right ones for you to be reported on. we will find the one that is asked for by CMS.
Okay.
You don't have to do any of the calculations, we do it.
So if it's not a per visit measure and I don't document it at every visit, then really I'll probably do okay as long as I capture it most of the time? Or is that?
Can you say that one more time, Lauren?
So how, I guess my question is, like, if I miss documenting the fact that that patient had a flu shot on one of their visits, that may not impact me, right? Because I might pick it up on another visit.
Absolutely.
Yep, that's true.
Okay.
As long as it's within the time frame, sure. And again, like we said, we do have the capability of manually be like, I missed it. Let me go, I can go update it in the visit itself as well. But we do have the capability of capturing it at a different date.
Great.
Hey, just
So,
I'm going to bump in real quick, Lauren, just let everybody know if you have any more questions, this is the time to get them in. We have our experts on the line just for a little bit longer, and we want to make sure if you have questions, if we don't get to them now, we will get back to you after the webinar is over. Thanks. Sorry. Continue.
can you guys talk about telehealth a little bit? I know that's a really big deal this year with COVID and how that's impacting some of our measures and measure tags, measure eligibility, measure performance. Talk about telehealth and our measure develop and which measures are eligible and how does somebody know?
Why don't you go ahead, Tara?
So with telehealth, sure. So telehealth is part of the measures where they allow for certain procedures and then they'll say with or without telehealth modifiers. So if you're billing with these modifiers along with these CPT codes, we can figure out if they're telehealth or not. And then based on what the measure specifications require, we will allow those visits as eligible or not. It's all part of the specifications. And so we go according to that. Telehealth is changing the world right now of patient care. And there, especially in 2021, there's a slew of measures that have been updated to now include telehealth as well. There are certain ones that they still expect you to do things in person, but it is changing the landscape, I would say, of what the expectation is as far as patient care is concerned.
So for 2020, they didn't actually change any specifications, right? It's just a matter of what it already said.
Exactly, yes.
But for 2021, they're trying to call that out more because it has become such a big deal and it's such an
Absolutely.
impact on care.
Mm-hmm. So we're able to identify which measures allow for telehealth and which ones we're not. I don't have that number off the top of my head though.
Right, and what they have is there are certain measures that explicitly say you can't do telehealth in 2020, and those are for 2021. I think what CMS will likely do is try to be more explicit about which ones allow telehealth, because often when we look at measures, and a question we now get a lot is, hey, are we allowed to do telehealth here? And when we look at the specs and we say, well, they're not, well, they don't say you can't do telehealth here.
Right.
You know, we're just saying, sure, you know. So I think one of those things that especially now would be more helpful is being explicitly, you can use these modifiers with these CPT codes, rather than us just being like, yeah, sure, it doesn't say you can't, so I guess you can.
I want to talk, so somebody just asked a question about CPT code 99072.
Mm-hmm.
I have a feeling that's a new COVID code, but if it's not in the spec from the beginning of the year, then it wouldn't help you or not help you with eligibility, right?
Right.
Yeah, and part of what CMS does, often we have to be on our toes, because, you know, these really CMS approves all of the measures, and we get specs and we start working on them, you know, October, November
of the prior year.
Of the prior year. But CMS will continually make changes to measures throughout the year, and especially with related to what I would expect, COVID and other sorts of encounters, I wouldn't be surprised if new CPT codes get added to certain measures through measure releases, even now at this point in the year, as submission is approaching, in order to help all those providers out there who have these new CPT codes. So what we try to do is we just try to stay informed as a registry and try to support everyone the best we can, knowing that, you know, if it doesn't say so now, unfortunately you can't use it, but if it's there, we're totally going to add it straight away.
Yeah.
So somebody just asked a question about benchmarking, which makes me want to go first, before we circle back to benchmarking, let's talk about measure strata, because I think that that's something we haven't touched on, and that is a, in my opinion, a complicated part of measures. So maybe first you can talk about what strata are, yes, and how they impact the calculations.
Yeah, sure, I can take care of that. So mathematically, statistically speaking, what strata are there's one population that is divided into exclusive groups. There's no overlap of them. So what we do is we take all eligible patients and we bucket them, and then we can report in those different buckets. A traditional stratification would be age stratification. That would be like measure 398, I believe, is stratified by different age buckets. So across different age buckets, we're looking for the same numerator criteria across different buckets of population. And then we also report the total as well. So you're able to compare the age bucket to all the eligible patients. That's slightly different in CMS. What they also have is called submission criteria. Submission criteria is identified as the different paths that you can get into the same bucket of eligibility. So there's measure 438, which I believe is like statin therapy, and you have different types of ways to become eligible for, there's 3 different ways to become eligible for this measure, but we report on them as one group. So CMS differentiates between stratified measures, and then different submission criteria for a measure. I think that covers it, right?
So versus measure 226, which is the bane of, I think, everybody's existence.
Yeah.
Cessation measure. And that's the one where CMS even pulled the benchmarks last year because they totally changed up. Can you talk a little bit about measure 226 and how that, because that's a different take on measure strata than the example you just gave, Tara.
So measure 226 is kind of, I like to say they're telling a story. And what they're doing is they're looking at the patients at different points in time, and they're reporting it as different strata. So it first identifies if you're a tobacco user or not. Then it reports if you were a tobacco user, did you get identified as having cessation and intervention? And then the third strata is actually a conglomeration of strata 1 and strata 2, which is all the non-users, all the users, and their statuses. Actually, this is a very funny, it's a different measure because we actually report strata 2. CMS is interested in amongst those tobacco users who had cessation and intervention, because that's really who we care to take care of. If you're a non-user, you're good. We're going to keep moving on forward with those that we actually do need to have some intervention with. So that's a little bit different. You're right, Lauren, and that's why I call it kind of the story of the patients.
Right. So I think that in a lot of measures where there are strata, which are, did you do the process? And you want to make sure that every patient is getting that process, like identifying that they're a smoker, or we just finished a lot of work on audiology measures. You know, did the patient get a hearing test? But then the outcome is really what's important. Did the patient stop smoking? Did the patient's hearing improve? You know, did their physical therapy result in better functional outcomes? And so what CMS has said is you can track those other measures. You can track, is the provider doing the action of the process? But then what they really care about, and Dr. Green, who's in charge of MIPS, keeps harping on this, is what's the outcome? Were you able to get your patients to stop smoking? Were you able to get your patients a better functional outcome on their knee, hip, shoulder? Were you able to, reduce the hearing loss that a patient is having? So, so a lot of those other strata are used more for figuring out maybe what the root cause of problems is. So if, for example, your patients, and sorry, I'm getting too passionate about this, but if your patient, if your patients aren't getting smoking cessation, is it because you're not monitoring them, or is it because you're monitoring them and identifying them, but then you're not taking the appropriate action? Same with, again, I'll go back to functional outcomes for shoulder, knees, and hips. Is it that you're not doing the steps along the way to make sure that your patients get in, or is it that at the end of the day, you're just not seeing that improvement? So it's helping you identify kind of where your gap in care might be so that you can work on shoring up that. In the case that you started out with 438, it's a little bit different in that you're looking at different patient populations because they do tend to have different outcomes, and then you're merging those together. So again, Tara, to your point, I think we take care of all that in the registry, but it's important for clinicians and their support people to understand what's going on and be able to dig into that data in order to achieve better performance.
Absolutely.
So I want to talk about two more things about, I like this because I get to be in control here. I want to talk about two more things about benchmarks. So somebody brought up that in the proposed rule for 2021, CMS has mentioned that they're not going to use 2020 benchmarks. And so, how are we going to do that for 2021 in terms of benchmarking? So I think what we're planning to do in Healthmonix is, because we have a big enough critical mass of providers, we have over 50,000 providers using our measures. If we have a significant enough population for any given measure, we can give you kind of a prospective benchmark that gives you a good indication of how folks are doing. But then what I want to talk about, and I'm going to toss this back over to Josh and Tara, is can you talk about like measures that are hard versus measures that are easy, and why you might want to do a hard measure in terms of benchmarking and MIPS performance and scoring?
Yeah, so when we look at measures and we look at benchmarks, one of the common things you'll see, especially after the last couple of years, are measures becoming topped out. And what this means is that in order to get the full amount of points, the most points usually you can get for a measure is 10 points for a measure. If a measure is topped out, what it means is that so many people are performing well in this measure that the benchmark is starting to become obsolete. If everyone's doing it, then there's no real, well, that's great, you're doing it, but it's hard to really grade people on looking at across the US, across different specialties, how well people are treating people for this measure. So when it's topped out, you basically need to ace the measure. You need to have full performance in order to get the maximum amount of points. So sometimes you see measures that seem easy to do, and one of the things you want to check is this measure topped out? Is this something that even if I do really well on it, I'm actually going to get the full amount of points for MIPS? Where some harder measures, where their coding might be a little more complicated, the data collection might involve some more steps, or you might be looking at some strata, you might be looking at some logic in there, you might be looking at a harder denominator. These measures might have more fair benchmarks where one, you'll have a better idea of how you're performing compared to other providers in the same specialty. And two, you also might have a better chance at getting more MIPS points, because if you're performing well on it, it won't be topped out, and you'll be able to see which decile, which kind of how you really fall into that measure, and be rewarded for those points. One of the things I think we talked about previously, just a little thing to tack on for that, is we also, us as a registry, and hopefully you as providers as well, we want to, like, the big thing for us is quality care. And we're only going to know quality care if people report on measures that they are not necessarily doing fantastic on.
Right.
So for us, what we do is we highlight your best measures in MIPS Pro to say, hey, these are the ones you'll get the most points on. But we want you to report as many measures which are simply applicable to you as possible so that you can identify where you need improvement. And some of those are the harder measures. So sometimes if you're working with us and you're selecting measures, we want to make sure you're selecting measures that give you a good idea of how your practice is doing and how you're doing as a whole.
So we're headed towards the top of the hour. I have thoroughly enjoyed having this conversation with Tara and with Josh. And if there is demand, I'd love to do perhaps another hour and we can delve into some more specifics. But those of you that had questions that did not get answered, we will get back to you one-on-one. And like I said, if there's other topics that you would like us to cover, please let us know and we'll see what we can do to accommodate that. Mike, did you want to offer any final words here?
Sure, I just put up on the screen how to contact us. If you have any questions, our contact information is below. There were a lot of great questions today. We really appreciate it, and there's going to be lots of follow-up needed from our team here. So thank you very much for joining today. If you have any questions, we'll be in contact. I'll also be sending you this presentation via video so that you can rewatch it on your spare time. All right, everybody have a wonderful, wonderful day, and I will talk to everybody soon. Thank you very much.
Thank you.
Thanks, guys.
Thank you. See ya.
Bye-bye.
Bye-bye.